glaucoma, cataracts, macular degeneration. As we age, our eyes can be the target of many problems. Eye conditions of the elderly tonight, on call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. So much of the world reaches us through our sight. We want to do everything we can to preserve and protect our eyes. First, let's take a look at this week's Prairie Doc quiz question. True or false? Glaucoma, increased pressure within the eye that can destroy vision, can either come on suddenly and be very painful or slowly and without any pain. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays originally written for this show comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only get 10 minutes to get your answer in. We're answering your medical questions about eye concerns as they're called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email to the address on your screen. You can give us a comment, but ask your questions. We appreciate those. Joining us tonight are Doctors Dustin Dierks and Greg Osmundson, both of Ophthalmology Limited. Thank you, gentlemen, for joining us.
Pleasure to be here. Thank you, buddy.
So, Greg, you tell me that you used to be a football player at SDSU. That surprised me.
It was decades ago.
You weighed how much more than you weigh now?
Oh, about 40 pounds.
Okay, so a few bit. And then you went where? SDSU undergrad, and then you went to?
University of South Dakota for medical school, did an internship in Sioux Falls, then went to the University of Missouri for 3 years of residency, did a one-year glaucoma fellowship at the University of Utah, and have been in Sioux Falls since 1999.
All right. And you're primarily specializing in
my fellowship was in glaucoma, but I still do a lot of general ophthalmology as well, a lot of cataract surgery. So glaucoma and cataract surgery, basically.
Yeah. And Dustin, what's your story? Did you play football for SDSU?
I did not have that extra 40 pounds,
oh, yeah.
So no, I did not. I'm from Mitchell, South Dakota originally, so haven't migrated too far from home thus far. Played for the mighty Mitchell Colonels back in the day.
Yes, a basketball hero.
Very proud of that. And then on to Augustana for undergrad, University of South Dakota Medical School, and then also to the University of Missouri for 3 years for residency.
Did you guys know each other at that time, or?
We did not.
A little younger.
Younger. Yeah, quite a bit younger. So, and then you came back after your training. Did you do a specialty, a subspecialty of any kind?
Nope, general comprehensive ophthalmology after Missouri, and went into private practice.
Okay. So there are, for the elderly, if you say elderly is 50 years of age or older, there are several major eye problems. What would they be in order of severity or danger?
Well, most people have heard of macular degeneration. That's the leading cause of serious visual loss in the United States in a certain age population. Before 55, it's more diabetic-related complications. Mm-hmm. And then after 55, most macular degeneration is the big issue. Glaucoma, as people age, can become a significant cause of visual loss as well.
And I was reading, Dustin, that cataracts are the biggest cause, the largest cause of blindness in the world, but not in the U.S., right?
Well, fortunately in the U.S. with our healthcare system, we're really fortunate, and most people have access to care. Getting your eyes checked at an early age, especially after 50, 55, 60 years of age. Eye physicians are very accessible, and luckily we have access to hopefully prevent that degree of vision loss here in the United States, which unfortunately isn't always the case in other countries in the world without that access.
You know, when I started practicing, I would see people in the emergency room at Brookings Hospital, and they would come in with these thick, like the bottom of a pop bottle, glasses, and you know, they had removal of the lenses, but they still couldn't see without a lens, and they didn't have lens implants.
Yeah.
They came in the 80s, I think, didn't they?
Unfortunately, they were just developing their cataracts a little too soon in life because implants have changed things a lot. Like you said, the thick glasses, now we implant a lot of that power right into the eye during cataract surgery. And so, fortunately, people may not need much prescription at all after surgery.
So I was reading also about trachoma, or am I saying that right? Tell me about that. That's an infection that's also in the world, but not in the U.S.
Generally in developing countries. It has to do with unclean water and sanitary conditions, and it's an insect vector that causes recurrent scarring of the conjunctiva, or kind of the whitish part of the eyes, and that can lead to scarring of the surface of the eye, and it's a major cause of visual loss in the developing countries.
Okay. So, but we don't see that here. But
Fortunately,
I think about it. I mean, it's treatable, right? If they had the antibiotics.
Yeah, azithromycin, one dose at the right age would take care of it, but that's difficult to get them into the hands of the people that really need it.
Yeah. You were telling me that you had an experience in Haiti doing cataract surgery. Tell me about that.
Yeah, well, Haiti's really not that far away from the U.S. It's in our hemisphere, obviously, and it's a developing country that has incredible poverty and poor medical care. And cataracts and glaucoma are the leading cause of blindness in that country. And we were able to go down with some of our staff from Ophthalmology Limited, along with some other doctors from the U.S., and do cataract surgery both on adults and on some children.
So that was 5 days of doing lots of surgery. That's amazing to me. You know, and they can see now.
Yeah, it was a lot of work. We have to transfer some of our technology. You know, without all our fancy toys, I wasn't able to help too many. But with the technology that we were able to bring down there, we could bring, first world technology to a developing country.
Well, and you made all that money, you know, doing it.
That's right.
That was. So, but you do a lot of cataract surgery.
Yeah, primarily my practice with Ophthalmology Limited is primarily referral based, and cataract surgery is the bulk of where a lot of my time is spent, as well as a lot of my colleagues and partners in the clinic.
So we have some video. I think I'd like to see if we can march our way through it, and you could explain some of what's going on with this procedure. Let's see if we've got that first one. This is the first one where, tell me what's happening.
Yeah, at this stage the incision has been made. As you can see, the cannula is through the incision, and at this point we are loosening up the cataract. The cataract is basically an M&M, and if you imagine the shell of the M&M is what we keep intact, and then we try to basically scoop out the inside of the M&M, and that's where we're loosening that cataract. Here is where we are inserting what we call the phacoemulsification probe. That device is about 2.5 millimeters across, and we're starting to break up the cataract. This is a little bit slow motion. It's usually a little quicker than that, but this is where we break up the cataract into smaller segments to remove it through the small incision.
Go to the next video there, Lowell, please. And then this is...
Yeah, and at this stage, the main part of the cataract, called the nucleus, has already been removed, and we're going in with another handpiece that aspirates, or basically sucks out, the very soft shell of the cataract called the cortex. And once this is removed, we are left with the capsule, or that M&M shell basically, in which we will eventually insert our lens. And so this is removing the just the remaining wispy edge of the cataract in a nice controlled fashion.
And the next one, Lowell, please. Oh, that's the last one. Yeah, let's go this one. This, are you putting in?
Yeah, and right here through that main incision, we're injecting a gel-like substance called viscoelastic, and it deepens that bag. So now that capsule or bag is much deeper, and we're preparing it for the intraocular lens, or lens implantation, which, as you can see, the lens is inserted and it's folded up basically like a taco, and it will slowly unfold eventually to then hopefully put a lot of that power that we were talking about earlier. Instead of having those really thick glasses, that unfortunately people had to wear 30, 40 years ago, we're putting a lot of that power right into the eye, into that capsular bag. And you can see how we manipulate the lens and it unfolds and eventually looks like this, which is about 6 millimeters across, is the size of that lens, and centered in the eye, and making sure the pressure is adequate to not have too high of a pressure or too low of a pressure when we are completed. And you can see the eye move at times. We're usually doing this with numbing drops, and it's very comfortable for patients most of the time.
Okay. Is the patient awake when this is happening?
Yeah, pretty much all of our surgeries patients are awake with really minimal anesthesia, sometimes no IV anesthesia, just numbing drops in a lot of cases. But you have to manage everybody's degree of anxiety and what one person may perceive as discomfort, another may not. So it's variable, but a lot of people don't need anything other than numbing drops when we do this.
I had a cataract surgery, and I don't really remember a whole lot about it.
That's the magic of the IV medication.
Yeah.
People frequently will ask, are there sutures involved? And some people might recall older relatives having surgery where large incisions were made and sutures had to be placed, and even several decades ago, they'd keep patients in the hospital for several days. They'd put their heads between sandbags so the wound would seal together.
Right.
Because of the changes in technology now, in particular the foldable lens that Dustin was describing, can go through a very small incision, less than 3 millimeters wide. And that incision, most of the time, will seal itself where you don't have to put a suture in.
No sutures.
And being able to fold that lens and keeping the profile very narrow has allowed us to keep the incision extremely small, and the patients just heal up much faster.
All right. Well, we can take any questions right now. I mean, anything about the eye at 1-888-376-6225. or ask at On-Call Television, oncalltv.org. Please give us your questions. This is your show, and it makes this a lot more fun. So I think about glaucoma when I think about you, because that's when I met you, and I had some glaucoma problems. Tell us about glaucoma. Greg, what is it really?
Well, glaucoma is a group of diseases that really comes down to a degeneration of the optic nerve. And the optic nerve is the main nerve of the eye that takes the visual information from the eye and sends it back to the brain for decoding.
Show us where the optic nerve is.
So the nerve is in the far back of the eye. It's something that we can see during the exam when we dilate your eyes. We can look in the back with those bright lights that nobody seems to like, but we can examine the optic nerve and assess the health of the optic nerve.
And this is the optic.
The nerve is here at the very end of the back of the eye, and that goes back into the brain for kind of the decoding, and that takes the information that the retina collects.
And this is the
sends it
retina.
back.
You're right.
The
So
retina,
this is the optic nerve.
That's right. The retina is the film of the camera, if you think of your eye as a camera.
Right.
And so glaucoma is the degeneration of that optic nerve. Pressure frequently is associated with glaucoma, and it is a major factor, but it's not the only factor. There are people that have normal pressure and yet have terrible glaucoma. There are people that have high pressure and don't have glaucoma at all. So it is a variable, and a very important variable, but it's not the only variable.
What could it be? I mean,
family history is a big part of it. The blood vessels that flow to the optic nerve and how much blood the optic nerve gets and how healthy the optic nerve is a factor. Often people would consider high blood pressure to be a risk for glaucoma. It makes sense, right? That pressure is high and the eye pressure is high. Well, it's really the other way around. Low blood pressure is a risk factor for worsening glaucoma because the blood cannot get to the optic nerve, and the optic nerve is really what's being damaged in glaucoma. Right. And there's other different types of glaucoma, and your first question alluded to that, but there are most glaucomas are chronic, and people don't know they have it. It's been called the thief in the night. Some glaucomas can be acute and can come up in a very short period of time and be quite uncomfortable.
So, but the majority of glaucoma, there's no pain, but some can be very painful.
Some can be. It's much less likely, but most glaucoma, there's no discomfort, and the visual loss usually can be extremely slow.
Well, and let's look at that. What is the visual loss of glaucoma is it the central vision or is it the peripheral vision?
Usually the peripheral vision. Sometimes those defects can be closer to the central vision as well, but it's usually the peripheral vision first.
We have a picture of peripheral vision loss where you can see the central vision, it's good, but the outside is gone.
That's right.
Now that is opposed to macular degeneration where it's just the opposite.
That's
show,
right.
show us a picture
Just the
of
opposite.
macular degeneration. Where the central vision, the picture of the two heads is gone, but you can see the ball and the...
And a very frustrating thing to see is when patients come in with both of those conditions, which is one of the worst things that I think we see, unfortunately.
Glaucoma combined with macular
Combined
degeneration.
visual field defects with combined central vision loss is an unfortunate occasion.
Well, blindness is a real deal, and it happens,
Yes.
doesn't it?
It does.
And sometimes it's nothing we can do. It occurs, they're blind, and our best bet is to try to help them live with it. And we could talk about that, but I'm going to take a few questions.
Okay.
A Belfouche woman asks, when you have macular degeneration in your family history, do cooked tomatoes have more of a benefit to your eye health than raw tomatoes? Well, that's a good question, an interesting question. I've never heard that one.
That is a good question.
Yeah.
I would say both are probably helpful.
Yeah, that's my
It's a
answer,
pretty
too.
healthy diet, and I think the key is the good components of the diet. I don't know if there would be, I can't answer that as far as if one would be better. I think both are safe bets on that one. And plus, the green, one thing to add to that is maybe some green leafy vegetables too, in addition to the tomato. Green leafy fruits, vegetables, nuts are really helpful for macular degeneration.
And there has been a study that has shown that people taking antioxidants, special formulations of multivitamins, can slow the progression of certain types of macular degeneration.
Well, and it's the wet ones, and so it's not the majority of them, really, isn't it? My take on it is, and I agree with what you're saying, but my take on it is your best bet is leafy green vegetables, tomatoes, fruits, you know, nuts, and a good diet, and all that supplement stuff is...
And if you combine that with no smoking would be an extra bonus.
That would be the best extra bonus.
Extra bonus.
That's right.
So, not, you know, I think, I looked at those original studies, and they weren't big.
It's not overwhelming. It's not overwhelming evidence, but if you have somebody that has mild macular and they know their mother did poorly with macular degeneration, it's nice to be able to offer something to say it's a lot of vitamins and some of it's not absorbed, I'm sure, and if you have a good, well-balanced diet, I'm sure you could get the same nutrients.
Right. And I kind of think I put the best preventative for macular degeneration is the same preventative for vascular disease, which is regular exercise and a balanced diet that's not excessive, and 40 pounds less than what you were in college, and then that idea of having communication with friends. You know, all those things help with your vascular disease.
Absolutely.
So raw or cooked are good with us. Sioux Falls woman has chronic dry eye with no relief, has tear ducts but still has pain. Do the doctors know of anything new or different to help with chronic dry eye? Ooh, Dustin, that's a tough question. You have a great answer?
That's a tough question we get every day, and it would be so nice to have one thing to help with dry eye, but unfortunately, it sometimes takes a lot of effort on the patient's part and a lot of trial and error. Artificial tears is a starting point.
Now, do you have a particular brand of artificial tears that you like, or do you know, over-the-counter that's inexpensive?
You know, I kind of stick with the inexpensive things. We give some brand names that they can start with, and I encourage people to talk with the pharmacist there and say, hey, what alternative would I have that's maybe a little cheaper? Because they're not inexpensive, the name brand drops.
Okay,
but
the artificial tears...
Artificial tears is the base for dry eye. We usually progress then how the patient's doing with maybe some ointments or gels at night. We then consider plugging the drains, the puncta of the eyelids.
All right, so you plug the drainage.
Yep. There's a little punctal plug, it's called. We can put in and basically block the drain and try to keep the tears on the ocular surface more. But then the newer medications, are not really new, but Restasis and Xiidra are two prescription medications that we use for people who are experiencing a lot more discomfort with their dry eye.
Now, explain how those work. I mean, they're very expensive, right? The Restasis.
Yes, that's a big detriment to patients' use of those medications. They are not cheap.
How do they work?
Well, they're trying to reestablish proper tear flow and the surface of the eye, making that the tear film is really made of tears and mucus and oil to try to keep that intact. And we generally will start with the simple things, with the artificial tears, and then maybe thicken those up. The downside of a thicker gel type drop is that it blurs your vision a little bit longer, but it actually lasts a little bit longer as well. I sometimes will have someone use one of their bottles of artificial tears and keep it in the refrigerator. Sometimes having it a little bit cooler will give them a little bit of relief, but that's temporary. That's temporary. And then the punctal occlusion, and then the Xiidra and the Restasis down the road. Mixed results with those. Very expensive. It takes a while for them to work.
Okay. Well, so, but a lot of people will rub their eyes because they have dry eyes. What about rubbing the eye? How bad is that for you?
That's not recommended. We have kind of a simple rule that if you're going to rub your eye, try to do it with open hand and rub kind of on the outside and try to keep the knuckles away from the cornea. Literally, you can change the shape of your cornea if you're a vigorous eye rubber, and there are people that can do that. There's a condition called keratoconus that can be associated with excessive rubbing of the eyes, and people with bad allergies can often have that problem.
So you would say, don't rub your eyes, or if anything, the outside only, you know,
Yep.
the outside only.
Yes, that would be the safest approach.
Okay. So the dry eye thing, we don't have any great answers, do we? That is a frustration. How about antihistamines? Do they help people who have, you know, like the Claritins and the Allegras and the Zyrtecs or the generic versions?
You know, they help if part of the issue is allergy related, obviously, but the problem and the catch-22 with this is that a lot of patients are having to use the over-the-counter allergy medications, which then unfortunately do worsen or cause dry eye. And so that's a dilemma. So if it's an allergic cause of the itching, we can treat that with allergy medications or topical allergy drops, but unfortunately that allergy condition may worsen their dryness from their medications.
And also those listeners and watchers that have glaucoma, some of the nasal sprays that are now over the counter do have steroids in them.
Right.
And that's not good for your glaucoma. Steroids can be an exacerbating factor, or flat out can be the originating cause of glaucoma, Flonase in particular, and there's others. So read your labels.
Well, I mean, for people who have allergic rhinitis, I mean, I've just leaned on the steroid nasal sprays, but I've forgotten about the glaucoma.
It's a real thing.
It's a real deal.
Absolutely.
Twice in her life, a Sioux Falls woman said, has woken up in the morning with blood in her eye that tends to resolve in a few days. She's wondering if there's something important to bring up with her eye doctor, and how soon should she seek help if it happens again. You know, whole side of the white of her eye turns red. Mm-hmm. What is that?
You know, that sounds like a subconjunctival hemorrhage, or where one of the thin blood vessels on the white part of the eye will rupture, and it can be spontaneous from an eye rub at night, a cough, a sneeze, and generally it's harmless and doesn't mean anything. But when we have some patients, sometimes we have it recurrently, we don't get too alarmed, but I have had a few patients we will send to their medical doctor, internist, asking, hey, can you check some of the blood clotting disorder, just to make sure nothing unusual is happening.
A CBC, and make sure, or you know, look at their meds, and a lot of times they're on an anticoagulant. You need to have them on it, and you just say, live with it.
Live with it.
Generally, it doesn't hurt.
They look a lot worse than they are. They're quite shocking, and it's almost always when they wake up first thing in the morning and someone says, oh my God, look at your eye. But
yeah, there's been an evil monster taking over my body. A Yankton woman asks, are Scandinavians more predisposed to glaucoma? This caller has a family lineage in which all the family has had it. Now, I'm a Scandinavian.
Well, there is a particular cause of glaucoma called pseudoexfoliation. So there is something called true exfoliation, and that's from glass blowers from the 17th century. So when doctors were describing this condition, they thought it looked a little bit like exfoliation, so they called it pseudo-exfoliation, and somewhat of a mysterious condition where a basement membrane, or this histological debris, if you will, is developed in the eye, and it clogs the drain of the eye, and it is more common in Scandinavians.
Oh.
And there is possibly some association with coffee drinkage, but I'm not going to tell anybody to stop drinking coffee.
Okay, good.
Because
I
my
wouldn't
mom will
want
get
to
mad
lose
at me.
my coffee drinking.
That's right.
I'm in trouble. Scandinavian, big coffee drinker. Of course, they're all coffee drinkers.
Absolutely.
If you ever read The Man Called Ove, or the Lady with the Dragon Tattoo, those are Swedish novels that are great fun. Coffee in their hand at all times. Cataract surgery is common, but as in any operation, care and watchfulness are needed.
So procedure only takes 20 minutes or so.
Well, today you saw Dr. Holm getting cataract surgery, and that's where we remove the cloudy lens in the eye and then replace it with what's called an implant lens, or a man-made lens, which helps clear up their vision. Once you remove that cloudy lens out of the eye and we put in that implant lens, that's permanent, and that just stays in the eye for the rest of the person's life, barring something unusual like trauma. But it's not, the body is not bothered by having that material in there. It doesn't cause any rejection problems or anything like that. We have the person use some antibiotic drops and some steroid drops to control inflammation. But we're checking them on day one, and then usually a week later to make sure they're not having any problems. Most of the time, problems are very, very rare. The main bad one would be an infection inside the eyeball. And that's why we use the antibiotics and we see them back, but that is very, very rare, luckily. Very common operation. In fact, numbers-wise, I think it's the most common operation in America. Almost all of us get some type of cataract as we age, and if you live long enough, you're probably going to have surgery to remove it, and you have two eyes, therefore making it very common surgery. Well, I just say overall, the procedure nowadays is only about a 10 to 15 minute surgery. Very easy to go through, not much pain afterwards. It doesn't lay the person up very long, which is nice. So in general, it's as far as surgeries go, it's quite easy to go through, and the results are usually fantastic. Patients are so happy when they get it done, and it makes for a nice surgery for the doctor also, because patients are happy and they didn't have to suffer very much. So.
Well, I was a happy camper, a good patient and a happy patient, and I thank Ken Knudsen for his wonderful help in that. This is your show. Your questions are key to our show discussion. Call in your questions about eye concerns to 1-888-376-6225, or send us an email to ask@prairiedoc.org. And we're going to get right into questions. And we thank you for the questions you've sent in. A woman from Sioux City asks, once you've had cataract surgery, can cataracts come back?
No, not the cataract itself. Frequently, there will be a little scar tissue behind the implant that needs to be lasered away. There's somewhat of a misnomer. People will call that a secondary cataract. It's really not a cataract at all. It's just a little bit of the scar tissue from where the implant was rested. And it's the same, what we call the capsule, or the little shrink wrap where the original lens came from. It's a great place to put the artificial lens. It just needs a little laser in the office, very simple procedure, painless, that'll clear things up.
All right. Spearfish woman wonders if there's anything that can be done to strengthen the eye to prevent eye strain. Dustin.
Eye strain's common. I think.
What is the eye strain?
Eye strain, I think a lot of times is mostly pertaining to near vision from my experience. Straining with reading, is the bifocal or the reading prescription quite strong enough? Nowadays, with patients using cell phones and iPads and engaged in that near work, you can almost strain your eyes more from computer intermediate vision, excessive without blinking. There have been studies that show you blink less often when you're engaged in a computer or iPad type use. So
Wow.
that can really attribute to a lot of eye strain.
That's me.
Yeah.
Stubborn 50-year-olds like myself that don't want to wear their reading glasses. That's eye strain. Eventually, you just give in.
But now reading glasses, let's talk about that a little bit. You know, I found a pair of glasses when I was sailing in the British Virgin Islands that somebody had fallen into the drink and they had recovered. And I wear those at night when I'm reading because I've left my glasses back. And my glasses have the lower side, but they don't have the better type that will allow me to read this far away.
Mm-hmm.
What do you think about that? I mean, you can go to the drugstore and get a pair of reading glasses cheap. Is that a decent thing to do?
I think it's perfectly fine if that's, some people just need the same amount of prescription for reading in each eye, and if they don't need much for distance, reading glasses work really well. Or if they're wearing contact lenses for distance, they'll just need the reading glasses, and I think they're really good. But if you need a prescription for distance, you're going to need that into your bifocal to make sure it's the correct prescription.
Oh, I see.
That's when the over-the-counter reading glasses won't work perfectly.
So you combine it.
Yes.
The person that fell in the ocean is okay.
I don't know.
It kind of sounded like he just took the glasses and.
Must have been
I
clear
think,
water.
I think the fish ate him and
Okay.
left the glasses.
Okay.
Or maybe the glasses just
Not a
fell.
total loss then.
I just love those glasses because you can just see this old codger leaning over and and there it went, and he went, oh, damn, I lost another pair. A woman from Sioux Falls wonders why would floaters appear more like fibrous material rather than circular material or cellular material. So floaters happen at something like 60, right? What are they?
Floaters are an attachment of the thick jelly in the back of the eye to the wall of the eye.
Okay, now show me where that.
And so the back of the eye is filled with what we call vitreous gel, and it starts out being very thick when we're young. As we get older, it gets synuretic or becomes kind of partially water-based, and the jelly will pull away from the retina at some point, and it'll leave a small amount of debris or an attachment in the middle of the vitreous cavity, kind of between your retina and the world that you're looking at. And often they're called floaters, which is an appropriate name, as they drift around in the eye. And they can be all different types of shapes. They're not always round. Some people say they're like spider webs. They're like ribbons or flies drifting around. The vast majority of the time when that happens, it's not serious, and patients usually just get used to them. Not always, but used to them. Sometimes a little piece of the retina will come with it, and that can cause a retinal tear, which can lead to a retinal detachment, which can be a very serious condition.
I think it's important that when people do notice floaters, if they're new or changing, it's probably good to go in and see someone, have your eyes dilated, because it's that rare case when a floater may cause that tear that we'd like to see soon.
Yeah. Well, I know that says something about my personality, maybe my psychopathology, but the floater that I had looked like the Madonna holding a baby child. I think, what does that say about me? Could the docs explain ocular migraines and macular holes? Dustin.
Well, two different topics. First, ocular migraines. Quite common. We see that a lot in the clinic. People come in with some temporary or transient temporary vision loss. Oftentimes they'll be followed by a headache and a classic migraine when you have a vision loss. But the ocular migraine is when you'll get this vision change without a headache. And that can be a vasospasm type situation where it will affect a portion of your vision, and instead of getting a headache, you get some vision change. Now, it's a tough one to diagnose, and sometimes we'll actually get a medical consultation or a neurologist to see the patient to make sure that's in fact what it is.
Now that's different than when people have migraines and they see
The aura,
aura.
the jagged lines.
Explain that.
In a typical or classic migraine, you will usually have a vision change where you'll see maybe kaleidoscope type vision, different colors, zigzaggy lines, and then typically we'll get a headache following it 15-20 minutes later, which is more of a classic migraine. And so the ocular migraine is when you get the visual symptoms without the headache.
Okay.
Macular hole, go ahead.
Go ahead.
So that's the ocular migraine. The macular hole is, unfortunately, if you have a floaters developing, or maybe not, but in the macula where people get macular degeneration in the back of the retina, Unfortunately, sometimes there just is a little hole that develops. It looks like a little teeny round hole, and that can unfortunately lead to pretty significant vision loss. And that's when our retinal specialists come into play, and they can repair that if caught early enough surgically.
So those are serious issues, and we like to know that we don't have those often.
That's right.
And of course, those visions are rarely not Madonna holding a child or anything, right?
Not the first time.
Okay.
But, just for you.
I think that's a sign of high IQ or
Yeah,
something.
that must be it. This woman would like to know if there's anything safe to get rid of floaters that stick together and impair vision, such as nutritional changes. Is there a nutritional supplement? Or
There really is no treatment other than surgery. Now, that's pretty rare that people have what they call a vitrectomy, which is removing that vitreous jelly for the floaters. And they can get rid of them, but it's a fairly involved surgery with some risk, and not many people that have floaters will end up getting that type of surgery, but there are people that are bothered enough by their floaters that that's necessary.
I've had a few patients who retina has, and we all have a few, but truck drivers, I've had a few patients who it's so visually obscuring that they need that to keep their line of work.
Right.
And so I have seen that surgery done for that.
A Watertown woman had cataract surgery in March, but ever since then her eyes are always watering, hurting due to dryness. Will this get better? Will she be able to read comfortably? Dryness after cataract surgery.
Probably not related to the cataract surgery. The incision from the cataract surgery is usually what we call the limbus, which is kind of the junction of the clear part and the white part.
Right.
Very small incision, re-epithelializes, or the skin kind of grows over it very rapidly. And so dry eye usually is not exacerbated by cataract surgery. I'd say that's most likely, unless she's still on some medication for it, it's most likely a coincidence that her dry eye seemed worse after the cataract surgery.
Right.
And you need to have properly hydrated cornea to see well. That's kind of why we blink. It's why we have tears. Just like the windshield wipers on the car, we need to blink every once in a while and get a good tear film on there to see well.
You know, I did some research on tears when I wrote an essay years ago for a show like this, and it's amazing the complexity of the simple tear, you know, the protein and nutrition.
Absolutely.
It's amazing. Plankton woman has macular degeneration, gets shots in her eyes to help. So that's a good topic we need to address a little. She gets an ablation every time she has this procedure performed. What could be causing this during the procedure? She gets an ablation. I don't know what an ablation would be.
I'm not sure what she's referring.
Okay, but anyway, she has macular degeneration and gets shots. Explain that, Dustin.
Yeah, well, macular degeneration, unfortunately, is a very common situation. As we're living longer and people are healthier, we're seeing more and more people 85, 90 plus years of age, and even younger with macular degeneration. 90% of it's dry, but unfortunately about 10% of the time it will convert to the wet kind, which is basically an abnormal blood vessel that will grow in the macula and will cause some swelling and loss of your central vision, that central visual blur that we saw in your photo. And luckily, our injections can be done to make that abnormal blood vessel kind of shrink away. It might take several repeated injections every month to 3 month time frame.
And what is it they're injecting?
They're injecting a medication that basically is a endothelial growth factor inhibitor that will cause that new endothelial vessel growth to retract and hopefully vanish.
Now, I've heard people just rave about those injections. I mean, I've heard, you know, very positive, and I always, well, you must have the wet. No, I had some dry.
Yeah.
You're not doing it for dry, though, right?
No, not for dry, no.
And that's 90% of it.
Yes.
That's right, yeah.
So unfortunately, we don't have anything for dry macular degeneration.
Not yet, but it looks like there's something that may be coming out in the future.
And how does that work?
I can't even explain it because it's not available at this point, but that would be a large group of patients that would definitely benefit.
Wow. A caller had cataract surgery in December and is now seeing double. Did something go wrong?
I don't think it necessarily means something went wrong. There can be a lot of causes to double vision, especially if it's after cataract surgery. It could be the tear film that you talked about, the complexity of the tear film, which could be changing after cataract surgery, which can cause a blurred or distorted image. Is it truly two double images, or is it somewhat of a hazy image? The lens implant, we always want to look at the lens implant. Is there any blockage behind it, as we were talking about with that laser that we can do to remove that? That usually needs to be checked and make sure everything looks good, and sometimes it might take glasses prescription to help with a double.
Would you ever take out the old lens and put a new one in? Or is that possible?
It is possible. It's not done very often. The reasons it'd be done is if there was something defective with the lens. Usually that'd be done at the time of the original surgery if it was damaged as it was going in or is not properly manufactured. If the correction, if the power of that lens was way off for some reason, and you were very nearsighted or very farsighted, that'd be a reason you might want to exchange the lens.
All right, we've got a ton of questions.
Okay.
So we want to go quick answers.
All right.
All right.
All right. Milbank takes supplements for prostate. No supplements have help for eyes. Are there any supplements that can help for eyes? Lutein, zethronin, microbite, bilberry, all that. Any?
It's similar to what we talked about originally when we were talking about the mild or the dry macular and using either Ocuvite or Prairie Vision. A good, well-balanced diet with a lot of leafy greens and non-smoking might be just as good, but that's kind of the quick way to do it.
And there is no real good supplement actually that helps aside from what you're saying. A caller from Clark asks, is it a good idea to wash eyes with eye cup using tea? Dustin.
I would say probably not.
How about washing eyes with water or special?
I think the safest thing is artificial tear, or just there's some saline solutions that you can
wash
use.
your
But
eyes.
mainly artificial tears are the safest thing to do to put in your eyes.
All right, but not tea. Probably not.
Probably not hot tea.
don't think
It'd be a
tea
bad
Particularly
idea.
hot tea, no.
No.
Sioux Falls woman heard that there are two kinds of glaucoma. What's the difference between the two, real quick?
Well, there's chronic angle closure glaucoma, there's acute angle closure, there's actually far more than two, but generally open angle and closed angle. When we talk about the angle, we're talking about where the fluid escapes out of the eye. Most glaucoma, especially in the United States, is open angle, where the drain looks normal, but for some reason further downstream the fluid is not being removed. The angle closure is when the iris blocks that drain, and you can see that on our exam.
And that's a congenital more than a...
It can be. It's more common in the Far East, and yeah.
Rapid City man saw a national news report in Southeast United States. There's a flurry of cases of melanoma in the eye. How common is melanoma in the eye, and how can it be treated, Dustin?
Melanoma, fortunately, is not very common, but it does happen, and we see it at our office occasionally.
From too much sun exposure? Who knows?
Who knows? If people have a history of melanoma being excised, for instance, melanoma, we are checking those patients usually once a year. We watch for abnormal nevi or freckles in the retina that can convert to melanoma, and so it's very important to have the eyes checked if there's any history of melanoma in them or their family.
Monitor, monitor,
Monitor.
How can you improve night vision?
Make sure you have a good correction. If you have a cataract, sometimes that's an early sign of early cataract and getting evaluated. Your pupils are larger at night, so if you have uncorrected refractive error, maybe some astigmatism or a nearsightedness that you're not wearing glasses for during the day, your large pupils are going to allow the image to be distorted more, so that's going to bother you more at night.
Wear your glasses.
Wear your
at
glasses,
night in
make sure you have a recent exam.
Recent exam. Yankton woman had cataracts surgery 4 years ago, and vision is continuing to get worse and suggested laser surgery. What would the laser surgery do? LASIK probably, or is it laser?
I would think she's probably referring to laser for our what we call a YAG capsulotomy, where we talked about that cloudy membrane behind the lens implant. That's a very common laser that we do that's very beneficial to help remove that secondary opacity.
YAG.
YAG.
A Belle-Fourche woman has tears on eyeball. They are not ripping any further and seem to be staying toward the edge. Is this common issue? I think she must be talking about pterygium.
It could be that, or it could be, it's possible she had what we call a recurrent erosion, maybe a tear of the epithelium. Usually it's somebody that's had an abrasion before, usually a traumatic abrasion, and then the surface of the cornea is still loose. Even if it's months or years later, it doesn't really stick down firmly, and often the patient will wake up first thing in the morning, the lids will kind of stick to that skin and peel a little bit off. It's very painful, and they usually come in tearing.
And do you help them?
Well, we usually, if there's a lot of loose epithelium, we might have to remove that. Often we'll place a contact lens to work kind of like a Band-Aid.
And it helps. You can fix it.
Definitely.
A man from Sioux Falls has high pressure in his eyes, but not glaucoma. How unusual is this?
That's common. Ocular hypertension, we call that. If you don't have any damage and it's not damaging the optic nerve, your pressure is okay. I often will treat someone if it gets really high, and even though they don't have any damage, because I feel like in time they might.
How long does it take to recover from a detached retina, and when will I be able to see again, Dustin?
Well, we hope they'll be able to see again. Retinal detachments, we can recover from those, but I assume they had surgery, and it can actually take several months. I mean, the surgery might repair the retina anatomically, put the retina back in its place, but it can take some time for all the retinal cells to function again, and unfortunately, depending on how extensive the detachment was, sometimes patients don't recover all of that vision.
Yeah. Pipestone woman had cataracts quite a few years ago, now suffering from double vision, which is kind of similar to the last question we had. Is this a normal symptom, double vision? Isn't that interesting?
No, it's not normal. If she had single vision, was doing well after her cataract surgery for a number of years, and now she has new onset, true double vision, true images, she needs to be seen. She needs to be worked up for microvascular causes, high blood pressure, diabetes, and
MS.
yeah,
Neurologic workup.
Absolutely.
All right. McCook Lake, we got 30 seconds. Lake man has a friend that has basal cell carcinoma of the lower eyelid. We'll be seeing ophthalmologists next week. Will the surgery be dangerous? Is it a common procedure? Basal cell cancer of the eyelid.
Very common. We have an oculoplastic specialist, an eyelid specialist in our clinic. Brian Hammer is very good. Usually they can remove most of that, but it needs to be monitored closely for years to come.
Omega-3 capsules for glaucoma?
Not proven to be effective.
And it's time to talk about the winner of tonight's Prairie Doc quiz question. True or false? Glaucoma, increased pressure within the eye that can destroy vision, can either come on suddenly and be very painful, or slowly and without any pain. True or false? Well, the answer is true. We talked about it. Glaucoma can attack your eyes either way. It was Shirley Morrison from Mitchell who answered the question correctly. Do you know Shirley? Thank you, Shirley, for participating, and a book will be in the mail to you soon. We'll be right back after this.
On call with the Prairie Doc is very important to a lot of people in this area and in this region, because it communicates a lot of very valuable information on healthcare, medical issues, answers specific questions. This project takes dollars. We have people in studios, and we have people that have to be paid, and we have to do production costs. Even though Dr. Holm's time, our time, the guest time is all donated, we still have production costs. We have a great foundation called the Healing Words Foundation that oversees this whole operation and is responsible for some of the fundraising to promote these programs. If you like this program and you enjoy the information you're getting and you find it's valuable, please feel free to go to our website and donate. We would really like to have some additional financial support, and it's very simple to do. And again, it'll keep this program going for the foreseeable future. So the website is prairiedoc.org, O-R-G, prairiedoc.org. Go there. Donate if you're so inclined, and we thank you very much.
More than 3.5 million people in the United States are legally blind or visually impaired. 21 million Americans have some eye condition that compromises their vision, and many of these problems could have been prevented. Mrs. E., who lived well into her 90s, would come into my office years before her death, never complaining about her age-related macular degeneration, or AMD. However, the diagnosis was obvious to me, because when she stared at my face, she would do so by looking 1.5 feet to the left of my nose. Since the AMD had destroyed her central vision, she used her peripheral vision to see. AMD is the most common cause of blindness in the elderly, and we know it occurs in certain families, in lighter complected races, and in heavy smokers. Mrs. E. was a heavy smoker. Almost the opposite of AMD is glaucoma, where the peripheral vision is lost and the central vision is spared. This gradual and painless loss of vision is due to the injury of the optic nerve and is commonly the result of increased pressure of the fluid within the eyeball, although it can occur in people with normal pressure, and it might not occur in people with increased pressure. About 2.5 million Americans have been diagnosed with glaucoma, and another 2 million don't know they have it. If diagnosed, treatment helps. Diabetic retinopathy is more common than AMD or glaucoma, with more than 5.5 million Americans affected. Diabetes causes new, tiny, and unfortunately very fragile blood vessels to develop in the retina. And when these delicate blood vessels bleed, they cause swelling, scarring, and progressive spotty vision loss. If caught early, treatment helps. Cataracts, which is the clouding of the lens of the eye, affects more than 22 million Americans and is the leading cause of blindness in the world. This condition is noted more commonly in obese or hypertensive people, in certain families, in diabetics, after excessive exposure to the sun and ultraviolet light, following eye surgery, and in heavy smokers and drinkers, and following the use of steroids, estrogen therapy, or statin medications. Preventive methods and cataract surgery help. For most of these eye conditions, there are methods to treat or prevent the blinding consequences. Yet, many people do not have regular eye exams. The message is staring you in your face, or perhaps 1.5 feet to the left of your nose. Well, a great big thank you to our guests, Dustin and Greg. Thank you for volunteering your time and your travel to our studio at the Yeager Media Center at SDSU campus. Their experience shed a lot of light on our discussion tonight. Well, we didn't have enough time to get to all the great questions from you, our audience, during our broadcast time. And if you'd like to hear the answers to those questions, please join us on our Facebook page as we continue with Prairie Doc After Hours. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Dementia has a variety of causes and treatments. What is happening with my memory? Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen District Medical Society,
Black Hills Medical Society,
3rd District Medical Society, Brookings, Madison, and Flandreau,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.